welcome today to this very, very special CCNV seminar. But for me, it's a very, very special CCNV seminar, I have to say, as I'm very excited that Anna Kufner is here today. We know each other since we studied together at the Charité in the Master Medical Neuroscience, where both of us were just like moving to Berlin, and then we're studying together for 2 years, and we're always learning together in the library. And it's like great times. I remember Anna was, after doing the master, then starting to study medicine. So first the academic track and then like studying medicine. Now she has become a neurologist, and now research is so happy to get her back as a junior group leader at the Charité and coming back to the academic track. Now with also the medical studies in the background. And then now we are happy that you are here today to present us about the works that you're doing with innovative MRI methodology in the context of clinical stroke research. So also for the students, maybe like such a field where it's exactly you need to be quite advanced in the methodology that you need to know in order to apply it to real world question, not the cognitive neuroscience of basic research, but like real world medical questions. And so I'm very excited to hear about your research, Anna.
Yeah, thank you so much, Timo. Hello, everybody. I'm also feel very honored to be here today, especially the talk right before the Christmas party. And also because to do a talk in front of cognitive neuroscientists, because I am a clinician, I am a neurologist, but I do come from an academic background. But the goal always for me was to take what I learned in medical neuroscience and in my academic career and actually translate it direct into the clinic. So my first disclosure is that I'm a clinician and I have a background in acute neurology, and I spent really 10 years doing a lot of research that's really basic clinical research. So always with a focus on stroke, but for 10 years I did studies developing new methods to identify patients rapidly in an acute time-sensitive setting for clinical trials. I also helped identify different MRI markers that could help us select patients that would most benefit from acute treatment strategies. I also worked with CT scans and tried to identify CT parameters that could help us identify stroke cause and therefore guide secondary prevention strategies. And I was also involved in several translational projects where we looked at novel MRI sequences that stemmed from preclinical studies and tried to see whether they had prognostic and diagnostic value for actual stroke patients. But doing these 10 years of real clinical stroke research gave me an access to a treasure of data that now allows me to study the human brain in a different way. So in the last 10 years, I worked with different stroke cohorts. These are sometimes randomized controlled trials or prospective stroke cohorts that have something like 1,500 to 2,000 stroke patients that came into the ER with an acute stroke and were followed up to 5 years, sometimes longer. And we have data on them about whether they developed a depression, whether they had cognitive impairment, how their speech developed, and how their pain symptoms were. So we had a treasure of data that allows us now to kind of look in a different lens into the human brain. So what I'd like to talk to you today about is I first want to go to a very brief history of how we study the brain, and then how we are now using lesion network mapping, a relatively novel methodology using a normative connectome, and how we can use this to study different complex post-stroke syndromes. For example, language deficits in the brain, but also depression that develops in patients after stroke, and also complex pain syndromes. Ultimately, I hope to then elucidate what this method means for us as neuroscientists, but also for stroke survivors. So to start this, I want to ask in the group, who can tell me who this is? I want to just tell me who, someone just say the name. We have a group of cognitive neuroscientists. You can also be wrong. come on.
Phineas Gage.
Yes, of course, Phineas Gage. This is one of the classic cases. This was an American railroad worker from 1848 who suffered a traumatic head injury where he had a steel rod go right through the frontal part of his, basically his frontal lobe, and he survived this and lived for 12 years afterwards, but he had a large personality change, and he had impulse control issues, and he was deemed one of the great medical curiosities of all time. So this is a classic case that all of you know and recognize, and it's because this is a classic lesion analysis that we used in classical neurology to understand that the frontal lobe is responsible for impulse control and parts of our personality. And these are two other classic patients that you may have heard of. For example, patient Tan, who had an aphasia and just repeated the word tan, 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 and essentially he had a lesion to his left hemisphere, which is the Broca area responsible for also language production, and patient HM, who suffered from epileptic seizures, and they removed both of the hippocampi, and he then experienced a short-term memory loss. So this is kind of the classic lesion approach where we understand structure, function in the brain, and we can imagine that over many years, this is how we learned how the brain works. So we have several patients with a similar symptom, and they have different lesions, and when we overlap them and identify the common neuroanatomical substrate, we can then infer that this part of the brain is responsible for this function. And this is how we all know this map that we all had to study, all of you surely as well. So we know that the occipital lobe is responsible, or it was where the primary visual area is, and the primary motor areas and so forth. This classic approach for lesion analysis has been developed a little bit further, and we can do voxel-based lesion symptom mapping, and this all works beautifully, and we even use this, I would say, in a day-to-day when we diagnose and treat stroke in the ER. So an ischemic stroke, to just kind of get to the basic, that basically is a blood clot that clogs a vessel in the brain and leads to no more perfusion of that tissue, and then we have the symptoms of stroke that can occur. And it is really important because it is one of the leading causes of death and disability worldwide. And when you look at it, 1 in 4 adults will experience a stroke in their lifetime. Yeah, so this is, you can count the faces in the room. It is relevant and important. So when we have a stroke, we have essentially a blood clot that causes a vessel occlusion, and then we have tissue that becomes infarcted, and then we have an ischemic penumbra, and depending where that is, the patients can have a various different amount of symptoms. They can range from loss of balance to visual deficits to facial drooping, a hemiparesis, sensory deficits, or speech deficits. I am a neurologist in the ER at Charité, and this is when the patients come into me, and then it's a time-sensitive setting, and we can essentially need to decide, is this a patient that is eligible for an acute treatment with thrombolysis to open the vessel, or mechanical thrombectomy to mechanically open the vessel, and then the patients go on the stroke unit, and the rehabilitation process starts. And in the last 10 years, there have been enormous advances in this acute phase of stroke treatment, and trying to get patients quicker to the hospital, to develop new treatment strategies. But this part, so the part after this acute setting, when they end up on the stroke unit and start the rehabilitation process, this is where the complexity really starts. Because what happens after stroke? We have over 80 million survivors, stroke survivors globally. And this is, they are then faced with the stroke. And it's not just that they then have the hemiparesis or motor impairment, but they also develop depression. And it happens after about a year, and it is chronic, and they do not respond well to treatment. We often see that even if the stroke is very small, patients will experience a rapid onset of cognitive decline. They develop central post-stroke pain syndromes. All of these complex neurological syndromes that we cannot fully explain through the stroke alone at the moment, and is very difficult for us to treat and have a very big impact on the quality of life and whether they succeed in rehabilitation. So there's a very complex interplay between what the lesion does to the brain and what it does with affect, cognition, and motor symptoms. And now we have to ask ourselves, how can we identify those patients that are at risk and what are actually our treatment options. Because at the moment, patients are just going into standard rehabilitation facilities. So now we can go back to this classic approach and we say, well, maybe it doesn't actually always work. So we have lesions that cause chronic depression and they don't localize to one specific area of the brain. So if we have different lesions, we have patients with the same symptom with lesions in different parts of the brain and they do not overlap. Well, we know that the brain is not that simple and we don't have specific parts of the brain that are responsible for specific structures, but it's actually a network that is very complex, structurally and functionally connected to each other. And so we need to look at more of a network, the network effects of these lesions. And so network and connectivity analyses in the brain, as you well know, we can do with these excellent techniques like fMRI and DTI. And I'm sure you're all familiar with, but this is very limited to us and to stroke patients that come with a large ischemic lesion and are really severely sick, and we cannot use this with patients that are really coming into the clinical routine. So a group nearly 10 years ago created a connectome, so a normative, functional and structural connectome in which they took about 1,000 healthy subjects that received an fMRI, and they calculated or created a normative connectome. This is open source, and what this allows us to do is to now take the lesions that come from standard clinical imaging modalities like structural MRI or even CT scans, normalize these into MNI space and do connectivity analyses to start see how acute stroke lesions affect connectivity in the brain. And Andy Hahn, who many of you may know, he essentially is a big part of someone at the Charité who developed this technique, but especially working with deep brain stimulation and Parkinson patients. And he essentially came to us and helped us establish this method in our lab to assess how stroke lesions, how we can use stroke lesions and use the normative connectome. So what do we do? Like I said, we have the lesions from patients with standard clinical routine MRI or CT. We can then delineate them, put them into MNI space. Then we use the connectome and can calculate connectivity fingerprints using lead DBS, just like they do, and essentially have individual connectivity maps per patient, and then we can analyze these and identify specific symptom networks. So what does this look like when we take a look at ischemic stroke? So here is just an example of 600 patients that came into the ER at the Charité. And we as neuroscientists and neurologists shouldn't be very surprised by these maps that we see. So patients that come into the ER with an acute visual loss because of the stroke, their lesions are connected to the occipital lobe. That's what we would expect. Analogous to that, patients that have lesions that are highly connected to the parts of the frontal lobe, they experience loss of consciousness and so forth. And we can essentially do this with different acute neurological deficits and see something, that we kind of know how the human brain works. And for us, this is essentially a proof of concept. But we can also use this to now understand more complex language circuits in the brain. So we know where Broca and Wernicke area are located, but we also noticed, for example, that patients that have isolated lesions to the thalamus experience semantic and phonemic fluency problems and impaired complex comprehension. So we also see patients that have lesions where we might not expect them to have language deficits also have them. So 50% of patients with thalamic lesions actually experience aphasia, and we took a look at 82 of those and did lesion symptom mapping and could find out exactly which nuclei in the thalamus were actually responsible for different subgroups of language, essentially, and then could take those lesions and analyze them using lesion network mapping, and saw that those lesions that were located in the thalamus that caused an aphasia were actually connected to a left dominant language circuit, with the strongest connections to the Broca area. So now we not only understand why lesions to the thalamus can lead to an aphasia, but when we now look at a patient-specific level and see how their network is actually spatially correlated to our aphasia network, and it can actually help us predict their development of language. So we can actually predict their aphasia score in follow-up settings, so direct also clinical application. And this is also a structural connectivity map of the patients directly stemming from this study. And we see that we can use these maps to actually identify potential new neuromodulation targets. So already in kind of studies at the moment, they're looking whether non-invasive stimulation techniques like TMS can actually improve and speech development over time post-stroke. And the idea is we can use this method to identify new targets. So what does it look like with post-stroke depression? Post-stroke depression is really an entity of its own, and it's highly complex. 1/3 of stroke patients actually develop a depression, and often for a very long time, we assumed that post-stroke depression was a direct result. Of course, the patient has a hemiparesis, no longer can take part of their lives. There's a clear reason why we have depression, but this is not the case. And what's interesting is that the post-stroke depression is absolutely resistant to SSRI, so serotonin reuptake inhibitors. It is a different entity. It is not just an adaptive syndrome that takes part as a result of adapting lifestyle. And patients that do have a post-stroke depression, they tend to fail at rehabilitation. They do not have good functional outcomes. And so we need to understand, is there a neuroanatomical basis of what's actually happening? Grefkes and Crick did a really nice study published in Brain 2023, where they did a simple lesion symptom mapping analysis of post-stroke depression and actually were able to basically take specific symptoms of depression, like emotional symptoms, cognitive symptoms, and so forth, and with lesion symptom mapping saw that lesions to specific areas of the brain actually cause these symptoms. So lesions to the insula, for example, was associated with somatic symptoms. We could expect this because the insula is also involved in vegetative function or autonomic nervous system function. They also saw that lesions that affected the middle frontal gyrus or the dorsolateral prefrontal cortex, they had suffered more from cognitive symptoms of depression, fatigue, difficulties concentrating, and so forth. So we see that there's a neuroanatomical basis, and we decided to take a look at our patients, and we took a look at 400 patients that entered the ER at the Charité. This is just a simple heat map, and these patients were followed up for 1 year. And again, we saw about 1/3 of these patients developed a depression 1 year after the stroke. And we can map out a network that is a symptom network that's associated with depression. And here again, we see regions, a complex brain-wide network that involves the middle frontal gyrus, parts of the thalamus, the frontal pole. And this, whether the patient is actually, the patient-specific lesion is correlated to this network, actually correlates with their specific or symptom severity. And when we take this depression network that we identified, it overlaps to a large degree with canonical resting state fMRI networks like the frontal parietal network, the salience network, the default mode network. These are all networks that have been implicated in major depressive disorder. So we see and we believe that perhaps these lesions cause a network dysfunction and disbalance in parts of the brain that are involved in cognitive control, decision-making, perhaps also attentional switching, mind wandering, and so forth. Now, we are not the only ones that have done this. So Siddiqui published a very nice study, I believe it was in Nature, where they identified a common depression circuit in 14 different data sets. So they had 5 lesion data sets and 2 other data sets where instead of using a lesion as a seed to do connectivity analyses, they actually used neuromodulation targets as a seed. And they identified a congruent or a consistent depression circuit across these networks. Another study also used other brain lesions and identified a depression circuit that actually has also the TMS target that we use for depression. So we see that we can use this method to understand the complexities underlying post-stroke depression. We cannot just say anymore the patients develop depression because they have a hemiparesis. We need to understand more what these lesions are doing with the brain. We can see which patients are at risk at developing this in 1 year time and hopefully use this to initiate secondary prevention and pay special attention to these patients. I'd like to also talk about pain. Yeah, so pain is also something we deal with a lot after stroke in the rehabilitation setup. 50% of patients after stroke experience pain, and they use some sort of pain treatment and are often also resistant to a lot of the classic pain treatments. And it is very complex because they have different kinds of pain. They have musculoskeletal pain, sometimes shoulder pain due to the spasticity of the paretic arm. They experience headache, but we also have chronic central post-stroke pain. So we know that also we have many pain pathways in the brain, and you can imagine if we lesion one of those, that we have a pathological perception of pain, yeah, or an augmented perception of pain. So we decided to take a look at this and here we had 500 patients, again, coming in, acute ischemic stroke, and we had a data set of patients that then we asked 1 year after stroke whether they experienced new severe pain after the ischemic stroke. This is first just a heat map of the lesions, and then we did lesion network mapping on those patients that reported new, very severe pain 1 year after stroke, and we identified a highly specific network that was essentially identical to one previously published in a small cohort of patients, just 17 patients that had diagnosed central post-stroke pain. And this network involves parts of the thalamus, the insular opercular cortex, primary somatosensory cortex regions, and the cingulate cortex. So these are very specific symptom networks that you can identify. And we ourselves were quite surprised that the network was so identical, based only on whether the patients in a simple quality of life questionnaire said, yes, we have new severe pain 1 year after stroke. And then we can actually take this network that we identify and run it through the neurosynth decoder. I'm not sure if you're familiar with it, but it essentially allows us to take the network that we identify and compare it to those from the literature. And this network also overlaps to pain networks, noxious, nociceptive, painful, so networks that have been identified in previous MRI studies, and it's just really highly specific. So we know that there really are structural and functional changes associated with post-stroke pain, and it explains in part why these patients are so resistant to the classical treatment strategies. So we need to use these networks to really develop our medical strategies further and treat these patients better. I just want to say 1 or 2 words on motor recovery, because this is, of course, something that affects the patients very much. They come in and they want to know, will I recover motor function of this part of my body or not? And we see that it is highly variable. So while some patients, we have patients that come in with the same initial motor deficit, and while some absolutely recover, some do not. And it is not easy for us as clinicians to say which patients will actually recover motor function or not. And Grefkes, this colleague, did a very nice review, essentially, and we have many fMRI studies that show that there are clear connectivity changes that are correlated with motor outcome, and we need to understand which pathways are compensatory and can help us identify or target those patients that are not prone to recovery. And this is just very preliminary results from one study that we did where we looked at stroke patients and wanted to see which ones actually recover gait, which ones can actually start walking after 1 year after the stroke. And when you map this with the structural connectome, you see certain pathways that are mapped out. And here, essentially, you see the cortical spinal tract. And the next step of this project is to hopefully identify new compensatory tracks that we might be able to target. So lesion network mapping goes way beyond ischemic stroke. I'm a stroke person, that's why I focus on this, but we can use lesions that don't come from ischemic stroke, but from multiple sclerosis or traumatic head injuries. But we can also use, like I said before, neuromodulation targets as seeds to do connectivity. And in the last 10 years, and maybe some of you know this, but in the last 10 years, very big papers have come out where we've essentially identified symptom networks of motor symptoms like dystonia and tremor, but also psychiatric like depression, hallucinations, and cognitive operations. And these are not just interesting to understand the brain, but they actually have direct therapeutic consequences. So Christos Ganos, who was at the Charité, who now just recently became a professor in Toronto, he took out about 22 patients from case studies that had lesions that caused tic disorder. So patients had no tic disorder before, had some sort of lesion to the brain, and then developed a tic disorder. And despite these heterogeneous lesions, they all mapped out again to a common symptom network involving the insula, thalamus, and basal ganglia. And not only that, but these patients then received deep brain stimulation, and he could show that as the deep brain stimulation, if it was connected, the strength of the connection to this network was directly correlated to the symptom improvement. So we can really use these symptom networks to target therapeutically. So what are the insights and future directions we can expect now from this? We see that symptom networks, whether it's depression or it is pain or it is cognitive decline, they are very symptom specific, but they are not disease specific. Yeah? And what's also very fascinating is that they are not domain specific. So where we have a symptom network that represents motor dysfunction, it overlaps with the symptom network that might be be responsible for mood. And so we have a big overlap of illness, symptom, and domain. And now we would like to try to use the complexity of this and actually translate it into clinical studies. And this is the basis of a larger project we are now doing as part of a CRC. And essentially, we are trying to identify networks where all different domains come together that we can actually target symptoms in a novel way. Just to briefly just discuss this project, so that what we are now doing is we're trying to investigate brain network interactions across behavioral domains to ultimately guide therapeutic stimulation for gait. That is a mouthful. I will try to break it down. In collaboration with colleagues in Würzburg, we are looking at now 4 stroke cohorts with about 1,000 patients and 4 deep brain stimulation Parkinson cohorts, and are trying to understand how different clinical phenotypes like cognitive operations, mood like anxiety, as well as motor function, gait, all come together, try to identify where those symptoms come together to optimize DBS therapy. And the idea is to hopefully identify a target that we can reduce non-motor side effects while actually improving motor function. And what does it actually look like? We just have large amounts of patient data, and we have data on motor symptoms, mood symptoms, cognitive symptoms over a large period of time, and try to now identify network nodes where all of these come together to try to stimulate and adjust stimulation there. So coming together, network mapping for stroke. I really truly believe this is a new method that we can use to understand the underlying neural substrates and pathophysiology of complex neurological symptoms like post-stroke pain and depression, and specifically to identify patients at risk. And hopefully now focus on those patients that are at risk and guide secondary prevention, and hopefully introduce more neuromodulation treatments for stroke. This is already happening in the field of DBS for Parkinson and dystonia. Andy Hahn, big name in this field, they are essentially targeting specific symptom tracks based on what the patient has. We don't now treat Parkinson with DBS, but we treat the symptoms that they have. Very specific patient individualized treatment options. And although neurostimulation is far from entering the clinical routine of stroke, there are a lot of emerging techniques with randomized controlled trial and early stage research that essentially is bringing now neuromodulation to the field of stroke. And I hope that these methods will be able to give us more options to actually treat stroke. So a take-home message, brain is parcellated in important parts that we should all know and be aware of which parts are responsible for which function, but we need to look at it way more on a connectivity basis. This locate the lesion that I learned in medical school as a neurologist, we need to move away and we need to navigate the network. I don't know who termed that, but I remember I read that we need to navigate the network. We move away from locate the lesion to navigate the network. When patients come into a hospital setting, we have to act fast. There are two main acute treatment options we have for stroke, but that is just the beginning of the story. And it is really here when the patients then pass the acute phase and they enter the rehabilitation stage that it gets complex, and we need to kind of expand our options as physicians. We need to understand post-stroke depression. We need to understand post-stroke pain syndromes. Understand who actually recovers motor function and who does not, and how we can optimize speech, for example, and also cognitive decline. And ultimately, I'm really hopeful that these methods will help us identify those patients at risk and give us new treatment options like invasive and non-invasive therapies. And with that, I'll conclude and thank you all for your attention.